Greetings. This is Marcia Erblund from the Division of Pulmonary and Critical Care Medicine, and welcome to the talk on examination of the chest, Part 1. I hope that the information in this talk will help you as you go through and combine it with your clinical exam sessions to feel comfortable and skillful in examining the chest. The examination of the chest will focus on several parts. First, we'll talk about just examining the chest itself. Obviously, that's a basic concept. I will include some aspects of the exam that are outside of the chest but are related to chest illnesses or pulmonary diseases. I'll go over some common pulmonary diseases and common symptoms and differential diagnosis. Some of that will be in Part 2 of the talk. This is a list of common chest problems, and it's not comprehensive, but it's some of the basics. So that includes diseases such as pneumonia, COPD, asthma, lung cancer, and abnormalities, which are signs or symptoms of another process, such as a pleural effusion or a pneumothorax. Some of the most common presenting symptoms that you'll encounter are dyspnea, cough, wheezing, hemoptysis, and chest pain that, for our talk, will focus on pleuritic types of chest pain. The physical examination has the four basic aspects that have probably been emphasized to you in other parts of examination, and we'll talk about inspection, palpation, percussion, and auscultation. Inspection is something often underemphasized, and yet you can learn a lot by practicing observing your patients. That means you start observing the patient as soon as you're close enough to see him, as you walk in the room. And this would be something that you would practice being more observant, so that when you see a patient, you can see something about his body habitus. That's the way he holds his body, and the shape of his body and the position. You'll also, when you examine the chest, actually look at the configuration of the chest. Another important thing that in number 3 in the list here is the breathing rate and pattern, which you might not think of as examining, but it's very important in assessing patients who are having certain symptoms or illnesses and may have a lot of importance for severity of illness. We'll also look at some common surface abnormalities and landmarks. So the landmarks are things that you'll work with so that you can describe things in a way that's easily understood by others and is reproducible. So this is just a set of drawings to show that you can see patients actually holding their bodies in a certain way that can be clues to chest illness. The figure on the left is a representation of a patient with COPD. You can see in that drawing of the man that his what we call accessory muscles of inspiration, the strap muscles in the neck, are tensed as they are brought into play in breathing in obstructive lung disease. And he's bracing himself on the chair, which also helps the mechanical advantage of the breathing muscles when someone has severe obstructive lung disease. The drawing on the right is a patient who is holding his arm and right side of his chest in a sort of a tensed manner to avoid moving. That's called splinting, and that's something that you may see when someone has pleuritic chest pain. They try to avoid moving that part of the chest. This figure just shows chest diameter in the AP direction. That's front to back. So the figure on the left shows that he has a normal sized chest from front to back. The figure on the right here has a chest which is broader from front to back. And of course, this varies, and there's a variation of normal, and you really won't be able to pick this up except in some extremes. But it's useful to look for. Again, these aren't subtle changes, so it takes more extreme severity of illness to show hyperinflation that you can pick up on physical exam. So another thing to remember as you examine the chest is we'll be learning that the physical exam is not the best or only way to pick up certain abnormalities. And while we're still talking about hyperinflation, I'll mention that the person has to have very severe COPD and significant hyperinflation before you find it on exam. So you would not want to say, oh, I don't think the patient has COPD because I don't detect hyperinflation. Instead, as we go along, you'll learn that pulmonary function testing is much more sensitive and is the appropriate way to make the definitive diagnosis. But again, you can have fun with and enjoy the aspects of physical examination that let you find some of these abnormalities. Here are some configurations of the chest. There are three different pictures. The one on the left shows pectus excavatum, in which the chest is somewhat what we call sort of caved in. The sternum is depressed or concave. This occurs in a certain number of healthy people and usually is not actually considered a disease, so that most people have normal function even with that shape of the chest. On the other side of the slide, we see sort of the opposite of that in the top figure, pectus carinatum. The sternum is somewhat pushed out in a more convex configuration, and the figure at the bottom right is a patient with very severe kyphoscoliosis, in which the spine is both curved and in the AP direction and laterally twisted. Now, this abnormality can cause severe restriction of lung function, and in more severe cases can cause respiratory failure. Here's a picture just to show you several things that you could see if you observed a patient before you even would lay hands on the patient. And you can see that this man's face is very ruddy or plethoric. And then it's a little bit hard to see, but down at the middle part of his chest here and along the side here, can you see this sort of bluish discoloration? It's pretty faint, but what that is enlarged veins. And this is an example of superior vena cava syndrome, in which the superior vena cava is obstructed and flow is very limited, so that collateral veins develop on the chest and the face may be somewhat swollen and suffused with blood, so that it looks very plethoric. Now we'll talk about palpation. And palpation just means when you're using your hands to touch the patient and detect certain abnormalities. it to assess the symmetry of chest expansion, whether each side of the thorax seems to expand equally as someone breathes in, and I'll show a picture of that. Palpation is especially important for superficial lesions, abnormalities, or for abnormalities in the musculoskeletal system. So you're actually feeling the chest wall so that you might find areas that are swollen or nodular or painful or tender to the patient. Lymph nodes come under palpation. Now, we don't actually feel the nodes in the chest because they're within the chest cavity, but we focus on supraclavicular and axillary lymph nodes as they may be signs of systemic diseases or diseases which have spread outside the chest. The other thing that we'll go over is that we use our hands to feel for the transmission of sound, as sound is transmitted from the larynx and the major airways to the periphery of the chest, the chest wall. That's called tactile fremitus. So this slide shows how we assess for chest expansion, and I'll give you an out on this. We don't actually do a very good job of detecting small differences in chest expansion. So I would say that most of the time you will use other techniques to show if there's a serious abnormality that you could pick up. You would use imaging techniques such as chest x-rays or CTs if there are very serious abnormalities. But nonetheless, this is the technique in which you place your hands somewhat below the scapula here, and you place them symmetrically with your thumbs in the midline, sort of along each side of the spine, and your fingers splayed out so that you're sort of gently circling the lower part of the chest. You should still try to be in the over the lower ribs below the scapula. And you have the patient take in a deep breath. And you just try to see if one side seems to move readily outward and upward the way the chest should when the person breathes in, versus whether one side is not moving as much. Again, I myself find it difficult to pick up any but the most severe abnormalities like this, but you can detect if someone is splinting. You can detect if there is major atelectasis of one lung. You wouldn't likely pick up very subtle changes. Or pleural disease, which could cause a trapped lung in which one side of the chest really does not expand well. Next is fremitus, and that's really a word that we use for a measure of the conduction of vocal sounds out to the periphery, so that it depends on the person making a vocal noise. So we have two types of fremitus: vocal fremitus and tactile fremitus. So vocal fremitus is how well you hear the vocal sounds with your stethoscope, even though they're both made by the person vocalizing. Tactile fremitus is how well you feel the vibrative sounds with your hand. We have the patient say 99. Now, he really can say anything, but 99 is chosen because it sets up a lot of vibrations, and it is a simple thing to say that makes sort of a constant noise. And then you determine if fremitus is increased or decreased. And you can imagine that that might be hard to tell. In other words, it all is based on what is normal as a reference point. So that's number one, something that you'll get a little bit better at with experience. And number two, you'll actually compare different parts of the chest, particularly side to side, the same part of the chest on either side, and try to get an idea of whether one side sounds about normal and the other is significantly increased or decreased. This slide shows two techniques we use in percussion. The frame on the left is just using the fist, and remember to use this gently, to gently tap on the spine. This is more for detecting some tenderness over the spine. The frame on the right is the picture depicting how we percuss the lung field to detect the normal aerated lung and the sound that it makes versus solid tissues and solid organs that have different sounds. So, in order to think about percussion, when you tap on the chest, and again, you'll have that demonstrated in your clinical session, so I tried to just show you an example of how you place your hand and your finger. But the different parts of the body, whether they're air-filled or solid or some combination, have different notes. So the note that we call flat or dull, and actually these are different. Flat is slightly higher pitched than dull, but they overlap a lot, are the sounds that you would hear over a solid tissue or water density. So a pleural effusion, or percussing over the liver, or over completely airless lung, such as lung that is atelectatic or very densely consolidated, will have either a dull note or an almost flat note. The normal lung sounds resonant, and that's the term used to describe the sound that you hear when you percuss with your hand, your fingers, over the normal lung. Hyperresonant is a sound that can be heard when there is actually somewhat less lung tissue present, but still basic lung structure, so over emphysema, and sometimes pneumothorax. That would be described as hyperresonant. So that there is a difference between emphysema and pneumothorax. Emphysema would have to be very severe to sound exactly like a pneumothorax, because a pneumothorax has no lung tissue at all in the area you're percussing, but a large amount of free air. And then a final note that we use is a tympanitic, and that's a sound you hear over one of the intra-abdominal organs, the stomach or the bowel, filled with gas. And it actually has a different sound than this hyperresonant sound. It has a higher pitched plinking sound, and you can practice that. So this next slide shows an example of where you would detect these percussion notes in your actual physical exam. So if you look at the picture on the left, this is a posterior view of a person. And the areas in red are the bones. So you see the scapula and the spine, and then the ribs have sort of a red overlapping with the green of the lung. So if you were to percuss over those bones, you would hear a flat sound. And it's really not your goal to percuss over the bones. You're trying to identify the lung field. So you would try to aim to percuss here in the green zone, and you would start at the top, the apex of the lung, and percuss down to here, to the diaphragm, where the diaphragm separates the lung, the chest cavity from the abdominal cavity. And if you percuss down this green zone and around to the side under the scapula, you'll hear the resonant lung. The second thing you would do is you percuss down the other side and identify when you get to the end of the resonant lung, and now you're at the diaphragm and over the abdominal organs. And you also can compare side to side, so that here you see you could compare the left side to the right side. So percussion in a very normal patient might just be going top to bottom, and it all sounds fine. But if you are starting to detect that something isn't right, you might have to go back and forth a little bit and compare side to side and top to bottom a little more carefully so that you can focus on what was it that you actually heard. Again, as we talk about using these skills to examine the chest, there's no question that you'll be using many other techniques to assess a patient with chest disease or to look for abnormalities in the chest. So, of course, there will be illnesses in which, or conditions, symptoms for which you get chest x-rays, chest CT scans, and your physical exam will complement those. But the physical exam is important because it's something that you're able to do right on the spot without any technology available. And it gives you a clue as to whether to move on to other technology. So it's something that as you go along, you are not going to rely completely on your physical exam for all symptoms and diseases, but it's quite helpful to feel comfortable in being able to assess a patient and think things sound reasonably normal and fit that into the total workup of the patient. If you look at the figure on the right now, if we do this in contrast, the figure on the left was looking, it just gave a representation of the back of a person and how you would percuss the back and the posterior lung fields. The figure on the right is to be thought of as if you were looking at the anterior part of the person. So you're looking at them, the front of the chest and the front of the abdomen. And it's showing you that if you are percussing anteriorly, and I usually like to do this with the patient semi-recumbent, because it can be hard to do with them trying to sit straight up because of the way the chest configuration, you're trying to do that, and they're slightly bent over, whereas if they're semi-recumbent or lying back at a slight angle, it's easy to get a good handle on percussion, the way you lay your hand on the patient and the way you percuss with your finger. So here, you'd be starting up at the top of the front of the chest, and as you percuss down, you should be over the lung. Here we'd be over the right lung, and you should be hearing the resonant lung if it's normal. Then there's not a outward picture of where the liver is, but this representation here shows that as you get to this area, you would be now reaching the point where the chest cavity ends and the abdominal cavity begins. And as you percuss over this area, you will get a different note from when you were percussing over the lung. Now this, I think, is a bit of a misnomer on this slide. As you get below the liver, you may then get what I call tympanitic sound if you have air-filled bowel there. Now the next slide uses chest x-rays, again, to show you that sort of x-ray vision of what's under the patient's chest wall. So you're percussing the chest wall, you just see the chest. You can't see these structures. So the chest x-ray shows you what's beneath. So again, it shows you that if you are percussing a normal patient, now we're moving over, looking at the left chest, the chest x-ray here on the left, and you're percussing down here anteriorly. This should be resonant. And then look, as you move toward the center, you should begin to hear an area of increasing dullness. That's the area of the heart. The more normal the person, the much smaller area will be occupied by the heart. On the right side, there's a patient with an enlarged heart, cardiomegaly. And you could get to the point where you could actually detect, oh, I am getting into an area of dullness much sooner than I would in the normal patient on the left, and the whole area of the heart is enlarged. So there'd be a much larger area of dullness, and a much smaller area of the chest would percuss as resonant. Now we'll get on to auscultation, which is fun for everyone to get to try to learn to use your stethoscope. And here's some examples of early stethoscopes, and thankfully we've advanced from that, but actually they were quite effective in changing the ability to hear things, and not only hear things at a distance, but getting a good seal with the bell of the stethoscope and having the earpieces, so that now we don't have to place our ears against the chest of the patient. So for auscultation, we focus on thinking about 3 different types of sounds. The first is the breath sounds. So important things to remember are that there are different normal sounds depending on the area of the chest you're listening to. So that we describe the normal breath sounds as being either vesicular, bronchovesicular, or bronchial. And we try to remember that it's abnormal to hear bronchial breath sounds over the lung periphery. They belong over the large conducting airways, and I'll show you a picture of that in a minute. The second thing is the adventitious sounds. So these are actually abnormal sounds that are superimposed on the breath sounds. And we divide those mostly into crackles or wheezes, and sometimes people use rhonchi. I like to use rhonchi for the coarse sound, but related to a wheeze. So it's not the same as a coarse breath sound. Don't say coarse breath sounds, but a rhonchus is a less musical, prolonged sound that usually means secretions in the large airway. And then there are other sounds like a pleural friction rub. So primarily you're listening for crackles and wheezes, and then other unusual sounds such as a friction rub. The other thing that you'll do, the third area, is to listen for the voice sounds. And we talked about this a little bit under fremitus, because we alluded to vocal fremitus when we were talking about tactile fremitus. So you're going to assess the sounds that are transmitted when the patient vocalizes. And so you'll assess vocal fremitus, egophony, or whispered pectriloquy. And I will have to admit, not many people do whispered pectriloquy. It's a lot of fun when you hear it, but certainly fremitus and egophony are often easily demonstrated in patients who have consolidation of the lungs. So we go back and emphasize the normal breath sounds. This diagram, these 2 pictures, show an anterior view of the chest and a posterior view of the chest. Again, trying to show you what's beneath the surface. You only see the surface, but you're connecting what you know about anatomy to where you place your stethoscope. So if you look at this picture, this green area, kind of green, is the trachea. And the sounds that you hear over there are harsh because they come more directly from the voice box and turbulent flow in the trachea. So it's normal to hear what are actually called bronchial breath sounds over this large airway. Then we have the yellow zone, and I think it's pretty hard to tell the difference as you fade from this to this, but nonetheless, the concept is they begin to be intermediate between bronchial and vesicular. And then we use the term vesicular breath sounds to describe the breath sounds made when you place your stethoscope over the periphery of the chest. So all the rest of your lung auscultation basically is around the periphery of the chest. And those are vesicular breath sounds. So all of those are normal, and you will get that feel for that with practice. So if you hear all of these in the correct places, the correct sounds in the correct places, we just describe the breath sounds as being normal. So you don't have to say, I heard bronchial breath sounds over the trachea and vesicular. You just listen to all these areas and you recognize there'll be slight differences in the way the breath sounds sound in a normal person, depending on whether you're over the large conducting airways or at the periphery. I just include this slide because it's a great example of what we try not to do, which is we try not to listen through the patient's clothing, because the clothing is not only a barrier but sets up extra rustly noises, and you really can't hear what we're trying to demonstrate if you don't get to the skin level. And we just remember when we examine our patients that we don't have to strip the patient completely to examine them, that's uncomfortable for the patient, not respectful. So you'll learn to expose a part of the chest at a time to do your examination so that the patient is comfortable. These figures are to show you the anatomy of the lungs in terms of lobar anatomy. So you may have learned, hopefully, that if you look at the figure on the right, this is an anterior view. So we're looking at the front of the patient. So if you remember, the right lung has 3 lobes, and the left lung has 2 lobes. So here they are. And then in the posterior view, here's the posterior view on the right. The right-hand figure is the posterior view. And it's really interesting because you only see 2 lobes projected posteriorly because the middle lobe doesn't really project posteriorly. The point of this slide is to recognize that if you see these colors, the colors represent the different lobes. It's to show you that you must place your stethoscope over the different areas of the chest, top to bottom, front and back, around the side, in order to hear things that are in the different lobes. So the lobes also have segments, and some of the segments may project anteriorly or posteriorly, and you won't hear things in one lobe or one segment unless you listen over the anatomical area that it projects to. Here's a lateral view. So on the right is a lateral view of the chest, the right lateral chest. So the right upper lobe is shown here in green. The right lower lobe is in the purple. And the middle lobe is in the orange. And again, you can see a significant part of these areas, these lobes, project under the arm, in the axilla, and down the side. So if you don't listen to this part of the chest, you may not hear findings such as crackles or consolidation in those lobes or in certain segments of those lobes. So here's the same thing on the left, but the 2 lobes on the left, which is the left upper lobe shown in yellow and the left lower lobe shown in this pink color. And interestingly, if you look at the left lung, it's almost like having an anterior lobe and a posterior lobe. So it surprises a lot of people to realize how the left upper lobe, which again we're showing here in yellow, extends really from the apex of the lung all the way to the bottom almost. And again, the lower lobe, we talk about it, calling it a lower lobe, but look how high it extends. So when you listen over the chest, you're trying to keep some of these anatomic correlations in mind. Here's our next picture, which again is still trying to emphasize lobar anatomy, primarily from the standpoint of showing you how you have to listen in the right place to be able to hear something. And if you skip that place, you'll perhaps think that the lungs are normal because you've skipped the very area where the abnormality is. So again, this is showing trying to show a right lower lobe pneumonia by showing the right lower lobe in red. So again, if you look at the figure that's the farthest to the left, and I've got this little arrow I'm going to put down at the bottom so that just the tip of the lower lobe projects anteriorly, just a very little bit, almost mostly to the side. A significant part of the lower lobe will be in this sort of lateral position, sort of the side and heading around toward the back. And then, as you might imagine, a large amount of the lower lobe is heard in the right posterior view. So whatever you're trying to hear, whether it's crackles, wheezes, validation, or rubs, you are practicing. If you look at this figure as a whole figure, if you look from left to right, you're trying to remind yourself that you must listen anteriorly, you must listen in the laterally, and then posteriorly. Next, we'll talk about consolidation. So you've probably already heard a lot about consolidation. We talk about it when we talk about pneumonia. And again, a reminder, listening for consolidation will not at all be the only way that you diagnose pneumonia, but it may be your first clue, and it's also something that you can do frequently. Say if you have a patient in the hospital, you can examine the chest every day, and you can become pretty good at hearing some improvement in that area, which would go along with improving pneumonia. So let's talk about consolidation. And what we mean is that the alveolar spaces are filled essentially with a type of fluid, but the bronchi are patent. Now, trying to be more generic, by that I mean there can be more than one cause of consolidation. So that's why I use the term the alveolar spaces are filled with fluid. You could have a severe amount of edema fluid filling the alveoli, or you could have blood filling the alveoli and produce those same changes. Whereas in pneumonia, it's an inflammatory exudate, cells and exudative fluid. The other important component of it, if you still stay on this top line, is that the bronchi are patent. So it's an important concept to have the alveolar spaces now filled with fluid instead of air, but the patent bronchi are running through that area so that the sound transmits better when it's traveling through a column of air in a solid medium. It seems sort of counterintuitive because you'd think the consolidation would make the sound travel less well, but sound travels better when traveling through a solid medium if there's a channel through it. So that the findings that we describe with consolidation include bronchial breath sounds heard, I have to qualify this, bronchial breath sounds that are heard where they shouldn't be heard, which is in the periphery of the lung. So not just over the trachea, but you'll hear bronchial breath sounds in a place where you should normally hear vesicular breath sounds. So that's point one. Second point is, in more significant consolidation, you may be able to demonstrate egophony, and we'll talk about that. And thirdly, the fremitus, both vocal and tactile, will be increased. So that means the vocal sounds that you either try to hear with your stethoscope or feel with your hand are actually increased above what they would be if listening or feeling through or over an area of normal lung. So again, the prototype, the example that you will encounter most commonly will be a lobar pneumonia or a large segmental pneumonia where there's a significant amount of congestion. So we'll go over bronchial breath sounds again in a little more detail because people have a lot of trouble. So it's a term that you use when you hear in the periphery lung the type of sound that's similar to that heard over the trachea. You then say that you are hearing bronchial breath sounds and where you hear them. So you would be examining the chest and you might hear bronchial breath sounds in the right lower lobe, and that would not be normal. To me, this is an interesting sound. It's pretty hard to describe, so it's something that you want to have demonstrated as often as you can because it's a harsher sound, but I also describe it as a more distinct sound than vesicular breath sounds. So vesicular breath sounds are kind of whooshy and soft and muffled, and the bronchial breath sounds actually sound more distinct and crisper. That may be hard to describe. So that it's not just a matter of loudness, but it has a different quality. So it's better conducted sound. Again, you have bronchial tubes, and these are small branching bronchi that go all the way out to the periphery of the lung, traveling through what's more of a water density now, the fluid-filled alveoli, and that's a sign of consolidation. So this is typically caused by things that cause alveolar fluid infiltrates, such as pneumonia, some inflammatory lung diseases, and occasionally you can hear these quite well over a pleural effusion or partial atelectasis, so not complete atelectasis and not over a massive effusion where there's no remaining lung, but at some of the interface between an effusion and a normal lung or the compressed lung, you'll hear these bronchial breath sounds. Fremitus we'll review again because we're under auscultation by focusing on the vocal fremitus. So it's a measure of the conduction of the vocal sounds out to the periphery of the lung. So for this, we said the vocal part is how well you hear the vocal sounds with the stethoscope. So again, we usually have the patient say something like 99 because that sets up a lot of vibrations. But really the patient can just be talking and you can still detect the increased fremitus. So that if there's consolidation, you'll hear these sounds better with your stethoscope than you would if the lung were normal. So again, the normal lung tends to muffle the breath, the vocal sounds. The consolidated lung transmits them to the chest wall where you're listening with your stethoscope. Egophony is an interesting sound. It's a lot of fun to demonstrate when you have a patient with pneumonia or a similar process. We also call it E to A change because it's simply where the patient is asked to say E, but you hear a sound that sounds like what we describe, the easiest thing to relate it to is a bleeding sheep or a bleeding goat. So it's not just A, but more of a ah, and you have to be sure the patient's actually saying E, because sometimes patients will not make the sound that you ask them to make. But if they actually say E and you're listening over normal lung, it will sound generally like an E, but somewhat muffled. Whereas if you listen over consolidated lung, it will sound like ah. So it's a sign of consolidation, usually requires somewhat dense consolidation, typically pneumonia, and typically a pneumonia like pneumococcal pneumonia that can produce very dense consolidation. Similar to some of the changes with bronchial breath sounds, you may hear this over an area near a pleural effusion. And again, you usually have multiple findings together so that you generally, but not always, don't hear just isolated egophony, but you would be picking up the idea that this is an abnormal area because you might hear bronchial breath sounds and crackles and other things that also are heard with areas of consolidation and pneumonia. So you can test the whole chest for egophony, but my approach is usually to bring that into play when I suspect something, either because I've heard abnormal sounds or I've heard asymmetrical sounds just with the normal breathing. So if I hear things that don't sound right, I'll move up to ask the patient to do some of this vocalization. And I don't have a separate slide for whispered pectriloquy, but that's a related finding to the increased sound transmission, so that we demonstrate whispered pectriloquy by having the patient whisper 1, 2, 3. It's important that he actually whisper it, and some people find it hard to whisper, so saying 1, 2, 3 is not actually whispering. You have to go 1, 2, 3. And you may, I don't know if you can hear that, but that breathy quality. And the reason is because with the normal lung muffles that sound further. So if you actually whisper, it's quite difficult to hear that with your stethoscope. Whereas if someone has consolidation and they whisper 1, 2, 3, it will actually be picked up and you can hear it quite clearly. Now I'm going to move on to just show you some radiographic correlations, and I'll walk you through these slides, which is a picture with 2 X-rays and a CT scan. And again, what I'm trying to do here is just give you a flavor of how anatomically you could envision what's going on inside the chest to produce the sounds that you're hearing. And again, this would be more real to you and more fun when you're actually seeing patients and recognizing that we have both the patient's history and the patient's physical examination and other data like chest x-rays, and you put them all together to come up with the constellation of findings and with the diagnosis. So if you look at the top left square, which is a chest x-ray, and I know this is a little bit hard to see, but we'll focus on 2 things. And I'll use my arrow in about 3 different places. If you look out here, this area, I'm sorry, we've sort of coned down on just the right upper lung here. But this area is much denser than the normal lung would appear on chest x-ray. When I say denser, it's a lighter color. Because as you probably have been taught already in some courses on x-rays or correlations with x-ray, the normal lung that contains a lot of air looks not really completely black, but fairly dark charcoal kind of color. And if there's increased density, increased water density, it looks lighter, so it stops the beam and shows up as a light gray, or in extreme cases even almost white. So this is consolidated lung. And now try to look really closely right somewhere like in here, and you see this sort of branching structure. So this branching structures are actually the bronchi. So what it's showing is that they remain patent, and that's what carries the sound through the consolidated lung out to where you can hear it. If you look at the x-ray now on the bottom left, I'm sorry it doesn't show up as well, but it's a similar finding. Again, this is now on the other side of a different patient, so it's in the left lower zone, and look at these areas kind of within that. You see, this is the bronchial tube, and you can see some branching. So what we're talking about is you'll be placing your chest x-ray on the outside of the chest here, and what you'll be hearing is the sound generated in the voice box and the bronchial tubes, large conducting bronchial tubes, turbulent airflow, and it'll be transmitted to the chest. And then if you look on the right-hand side, that's a CT scan, which shows you a little bit better. Again, we're still in just 2 dimensions, but it's cutting the patient in a slice. And I find that helpful to show you what you're doing with the exterior of the patient. Your stethoscope is placed here, but what you're hearing is the transmitted sound through those bronchial tubes running through the consolidated lung. This is also a good example of how where you place your chest stethoscope makes a difference, because again, if you look at this picture and now look toward the bottom of the picture, which would be the back of the patient. The patient's lying on his back. Look at the bottom where I put an arrow. You can see if you listen here, you'll be listening over the normal lung that here is shown in black. And the area of interest is in the anterior part of the chest. So you can listen all you want in the posterior part of the chest, and you won't hear this tremendous consolidation unless you get to the area of the chest where the lobe projects. We'll just look quickly at some other examples. Here are 3 chest x-rays, again, to show you what's under what you're listening to. So that here's a right upper lobe pneumonia in the upper left. Here's a right middle lobe pneumonia in the lower left. And here's a area of consolidation. If you look at the x-ray, which is a lateral view on the right now, that's a superior segment of the lower lobe. And again, you can see how high up that goes. So you'll be almost feeling like you're listening in the upper part of the lung, but the lower lobe extends to that area. We'll talk about crackles. Crackles are staccato sounds. If anybody still eats Rice Krispies, the sound when you pour the milk over the Rice Krispies, or some types of crackles sound like Velcro being ripped apart. Other people describe it as if you take some of your hair between your fingers and rub that, close to your ear, it makes those little staccato sounds. So they're short, interrupted, crispy sounds. And they're found in areas of increased alveolar or interstitial fluid. They may also be found in areas of scarring or fibrosis. And crackles are not very specific, so it's important to remember that here under this line, they're found in many conditions: pneumonia, inflammatory lung diseases, interstitial lung disease, areas of scarring, pulmonary fibrosis, and heart failure are examples. So that just hearing the crackles alone doesn't tell you what's wrong. But one of the things that you'd focus on that will, I'm sorry for my arrow problem here, I'll try to get that a little better. If you focus on several aspects of your crackles, one is the location. So not just the lobar location, but are they just in one place, focal, or are they diffuse, or mostly at the bases of the lungs? That may help sometimes with your differential diagnosis. So that's one thing. Second thing is, are they associated with other signs of consolidation? For example, with pneumonia, you may get a lot of signs of consolidation along with the crackles. And then again, you'll have to correlate the physical exam with many other clinical features and with your chest x-ray. Wheezes and rhonchi, some people, as I said, some people categorize everything as a wheeze because wheeze is a long, sonorous sound compared to the interrupted sound. So that's okay. Technically, there are these two main categories. So wheezes are long, sonorous musical sounds. Wheezes are usually somewhat high-pitched. They're quite diffuse, and they're a lot present in expiration in diseases like COPD and asthma. They can also be inspiratory, particularly in asthma. Patients with asthma may wheeze on inspiration and expiration. You can get a focal wheeze with lung cancer or certain other focal obstructions, so that you can have a wheeze just over one part of the chest. Now, that would imply obstruction in this one area, so that would make you think of lung cancer or a foreign body, whereas in the line above, when we talk about COPD and asthma, those are diseases which can involve the airways diffusely, and so your wheezes should be all over. Also, in the last line here, note whether you hear the wheezing just over the larynx or whether it's actually in the lung, and that sounds somewhat different. So if someone is wheezing only at the larynx, there'll be more of a singular sound, so not necessarily monophonic, but almost monophonic, with just that one sound, and that's the same sound you hear throughout the lung. Whereas if there is wheezing throughout the conducting airways, why we use the term musical, because there'll be different notes and coming in sort of different timing of the sounds, instead of one single sound that's transmitted everywhere. Rhonchi, I do use the term rhonchi, which is a long sonorous sound, but I use that to describe sounds which are lower pitched than wheezes, and they're also sometimes gurgling or snoring type sounds. So this is the typical sound that's produced by secretions in the large airways, so that when you can separate the idea of wheezes or rhonchi, it implies different things, so that someone who just can't clear their secretions may make the sound of rhonchi, and that's not the same as the musical wheezes that are classic for asthma. So as we're finishing up, other exam findings that are important, and these are not all of them, but just two of the major ones, are pleural effusions. Pleural effusions are very common in many diseases, and so there are a host of diseases that will cause pleural effusion. It will be difficult for you to get through much patient experience without encountering someone with a pleural effusion. The findings in pleural effusion include decreased breath sounds and dullness to percussion. So breath sounds may be decreased, and on percussion, the note will be dull. But you may have some bronchial breath sounds and egophony at the upper edge of the effusion. So there is some confusing overlap between just classic pneumonia consolidation and some aspects or some areas of the chest that are affected by the pleural effusion. This just gets back to what I mentioned earlier, that you will not, in modern medicine, make all of your decisions about what's in the chest by whether you hear bronchial breath sounds or egophony. If you have a patient with that significant of an illness where you can detect these abnormalities, you will be getting chest imaging, and that will help you tell the difference. There may be a friction rub, because a lot of pleural effusions could be inflammatory, particularly with pneumonia. And remember that a pleural effusion is a manifestation of some other process, so it may be combined with other diseases. The second, perhaps not as common, but really major problem is a pneumothorax, and in that case you'll have decreased breath sounds, decreased vocal sounds, and hyperresonant to percussion. So if you think back to our pictures of consolidation, the pneumothorax is the opposite of that. So the pneumothorax is air in the pleural space where there's a large amount of air separating the lung from the chest wall. And that means the sounds can't be transmitted to the chest wall where you've got your stethoscope. The air acts as a buffer and blocks the transmission of the sound. So here's just a picture of that. If you look at the picture on the left, it's just a schematic drawing so that here, if you look where the arrow is, this sort of pink area is showing the pleural effusion as fluid. So you can see that the lung is slightly pushed away from the chest wall. And what we talked about is, in its most basic sense, if you're listening here, where the arrow, if you're percussing here where the arrow is, or listening here, you usually would hear, you would have dullness to percussion and diminished breath sounds because the breath sounds aren't well transmitted. But it's a common feature if you're listening up higher that you get what people have described as some aspect of some compressed lung sound, so that the findings of consolidation take precedence or what you hear more than the reduction in transmission of sound. And then here on the right-hand side is just a chest x-ray showing a very large pleural effusion. And so you could see, we'll get our arrows again going down, you could see that if you are percussing this chest anteriorly, so you start with your percussion finger right up here, you'll hear some resonant lung right here at the apex, right? But as you move down here, it'll start to change because fluid's actually in 3 dimensions, and this slightly gray zone means there's some fluid tracking up around the lung. And then as you get farther down, it'll be dull to percussion because this is just now complete water density. And finally, we'll just show a similar schematic of a pneumothorax. And I've tried to show three different representations. So the one on the left here is showing just a diagram. So here's the lung, and this zone here now shows there's a pneumothorax, so that the lung can either just partially collapse, or it doesn't have to be completely collapsed, but is somewhat collapsed, so that there's now a space where there shouldn't be a space. There's an air-filled space. Now if we move over to the radiographs, the top picture is a chest x-ray. So the top picture here on the right is a chest x-ray. And look at the difference in density from side to side. So here's the right side of the chest is very black. And it's not actually supposed to be that black. So that's pure air. Whereas on the left side, which is the normal lung, you can see is more of this slightly charcoal color, because even though there's a lot of air in the lung contains some lung tissue and blood flow that make the density not completely black. So it's not completely air-filled. So here, so we go back to the right side, and here, look back at the pneumothorax, and then look right here toward the hilum. This is actually the lung. This is what in Arkansas we call the lung fritter. And this lung is completely collapsed down to just a nub. There's no air, but it would re-expand if a chest tube were placed and air were drained out and the lung allowed to re-expand. Now, in the bottom right is a CT scan, which again I show because it slices the patient up in a way that helps you see in the dimensions that you can think of when you place your stethoscope. So Here's the pneumothorax, this black area. Here's the lung that's pushed away. But you're not going to be in the chest, right? Your stethoscope's going to be out here, say in the front, listening to what you try to hear, the breath sounds. So as you listen along here, you can see that you won't hear sound because the lung is now here, and all that space in between prevents the transmission of sound to your stethoscope. So I appreciate your attention. That's the end of session 1. Thank you very much.